Okay, guys, we're moving on with chapter 12, um, primary assessment. So, when you just did scene size up, which is your first deal, okay, so you show up to the scene. As you're approaching that scene, your assessment really has begun for scene safety, um, any hazardous material, that kind of stuff, mechanism of injury, how many patients, and how much resources do you need. Now you're past that phase and you're in your primary assessment phase. Um, so with that said, we're going to be focused on those things. So focus on life threats. When you approach the patient, and your assessment is going to be different every time. I mean, you guys are going to see as an EMT many different varieties of situations, from a broken ankle to a head cold to a trauma accident with a very large mechanism of injury. So every scene you have is going to be different. So it'd be nice to be able to say, do your primary assessment same every time. Like it makes sense that ABC, right? And you guys are getting ready to take CPR on Wednesday, first aid. And I'd like for all of you guys to be there. Even if you have CPR first aid, it's a it's a great refresher, and you'll get some from it. But as your ABCs, now they teach CAB, circulation, air, and breathing, instead of breathing, circulation, and airway, breathing, circulation. So it's all different. Um, so this may vary depending on patient's condition. When you show up to a patient, if they got a broken ankle, obviously they're breathing, their ABCs are covered, right? You're like, hey, I'm Scott with the Cheyenne County Ambulance. Why'd you call us today? Well, I broke my ankle, so you know their airway there, you know they're breathing, and you know they got circulation because their skin is pink, warm, and dry. So it varies on the patient's condition of how you do your assessment. How many EMTs are on the scene to help you? That changes how you do the assessment. Other priorities you determine as you assess the patient. As you go through, you're going to have other priorities you have to do. So if you're doing a head-to assessment and you are at the head and you find a gaping head wound with a lot of blood, now you got to control the bleeding and changes your assessment. So just look for those things. The primary assessment is the portion of the patient assessment during which you will focus exclusively on life threats, specifically those that interfere with airway, breathing, and circulation. That's the main thing. So a quick head-to assessment and intervene with any major life threats. Um, so anyway, the ABCs depends on initial impression of the patient. So when you go up to them, your first impression determines how you're going to do that assessment. Sequence will vary from ABC if the patient has signs of life, and then CAB if the patient appears lifeless, no pulse. So again, when you go up to the patient and he says, "Hey, I really need your help on this," he's talking to you, so his airway's open, he's breathing, and he's got circulation. That's going to change your assessment. Now, if you go up and there's no signs of life, now you're CAB mode. You got to do circulation and get that airway open and breathe. Immediate interventions may be needed. Any vomit in the airway that enters the lungs is very serious and often fatal. That is a true statement. There's many people who have actually passed away because of choking on their own vomit and they get in their airway and in their lungs. That will make a decision. So if you're going ahead to assessment for your primary assessment and you see they're choking, that changes your assessment because now you got to suction and get that airway open. Um, any kind of bleeding must be stopped immediately when there's a bad trauma. Obviously, you got to control that bleed because it's basically a broken hose. You got to get that stopped, and breathing and circulation are absolutely vital for life. So the ABCs is everything revolves around that. So when you first go onto a scene, it's going to be ABC or CAB, depending on your primary assessment of that patient. So decision making in the primary assessment. If immediate interventions such as bleeding control or CPR are not required, shift into important but less urgent mode in which you will administer oxygen appropriate for the patient's condition and evaluate for shock. Um, you know, if the patient needs that stuff, that's what you're gonna do. So um, keep in mind that the first steps of primary assessment will depend on your initial impression of the patient. And as already noted, if the patient shows signs of life, you will begin to work through ABCs in order to dictate by your patient's priorities. So as you go from top to bottom of the patient, you're going to have priority list as you go through, and so it's going to vary. So approach to the patient. So there's a graph in page 285 that is really good, kind of way that I kind of filter through things. As when you approach the patient, you check for responsive and perform a quick scan of the chest for breathing. So that is absolutely crucial. So when you walk in the room, like I said repeatedly, ABCs. If they talk to you, you know where they're at. So there's going to be two directions that you go when you walk into a scene with a patient. Is either they're lifeless and pulseless and unresponsive, and now you got to take initial act and start CPR, or there's signs of life with pulse and breathing. So then that determines how you go in that direction. So the primary assessment is generally considered to have 6 parts, and we'll go through those 6 parts. Forming a general impression, that's absolutely true. How serious is this call? How serious is the situation? How serious is the patient? Assessing mental status. Hey, Bob, I'm Scott with Cheyenne County Ambulance. Why'd you call us today? They talk back, and then you can ask them questions like, well, do you know where you're at right now? Um, you know, we want to know if they're awake and alert and oriented. And a lot of times you'll hear me say on the radio, I'll say AAO times 4. That means that they're awake, alert, and oriented times 4. That means they're awake and alert and oriented to time, location, and place. Anything beyond that can equal a mental altered mental status. So you want to gauge that. Assessing the chief complaint. What brought us to you today? Why'd you call us today? And well, I've had a lower abdominal pain for 2 days now, and I just won't go, and I can't sleep, and I'm starting to vomit, and I'm really nervous. So their chief complaint, you know what it is. You always want to get that right off the bat. What brought us here? A lot of times dispatch will tell you what a chief complaint is, but that doesn't always mean that's accurate. They're doing the best they can. But I one time was paged out to a car versus deer accident. I get on scene, it was actually a car versus semi. No deer even in the picture. So the chief complaint was completely different than what I was expecting. So you always want to make sure and confirm that. Assessing the airway, make sure it's patent and they're breathing. Circulation, skin, pink, warm, and dry. Check the cap refills. Determining patient priority. Are they a load and go or stay and play? That will be crucial, and you will fail if you do not pinpoint during your practicals if the patient is going to be a load and go or stay. That is extremely important, and it's going to be on the registry as well. So a form of a general impression is assessed environment, patient's chief complaint, and appearance. So walk in the room. What's their chief complaint? What's the environment look like? And their appearance to that. If they're sick, and they're during flu season and they're sick and they've been vomiting for 2 days and they're dehydrated, their appearance is going to show that. If they're a diabetic with very low blood sugar, their appearance is going to show that. So again, when you form a general impression, it starts as soon as you walk in the room to the point where you start reaching the patient. Help determine patient severity. Load and go, stay and play. Pain's a 1 out of 10, or 1 out of 10. The pain is the worst it's ever been. It's a 10. Helps set priorities for care and transport. The look test, filling from environmental observations as well as the first look at the patient. An example is in your book. Boom, there's an environmental issue right there. My Lord in heaven, that is a horrible situation. But that's obviously going to determine some things with you. So you're assessing the patient, but you're also looking at the environment. Are they clean? Are they not clean? Is there drug paraphernalia laying around? Is there, alcohol bottles roaring around everywhere? Form of general impression. Immediate assessment of the environment. So at this time, the patient's chief complaint appearance. So obviously you walk up to this girl, hey Sarah, I'm Scott with the Cheyenne County Ambulance. What happened today? And obviously she fell and banged her knee. So you can see though, her skin is pink, warm, and dry. She's awake, alert, and oriented. I can't talk to her, she's a picture, but assume that. And she's trying to stop her own bleed right there. So obviously this is not a load and go situation, but a stop and let's get this bleed under control situation and make her feel better. Identify patients who may be critical. Patients who appear lifeless, resuscitate by beginning CPR, compressions, right away. You walk up to a patient, boom, CPR, boom, boom, boom. Prepare an AED as soon as possible. In the situation, you're going to start compressions right away. Tell your partner to grab the AED, cut the shirt off. The partner's going to put the AED on the chest as you're doing it. And then when it's time to start shock, you're going to start shock, step away, shock. You're going to work as a partner on this. But immediately when you walk in, your primary assessment is, man, they're lifeless, boom, compressions immediately. Patient who have an obvious altered mental status. Hey Bob, what's going on today? Well, the robots have been chasing me for 3 days and I just don't know where I'm going. As a matter of fact, actually, I went on a call a couple years ago out at 94 Junction for a lady who was pulled over by police and started taking off. Well, when they took off, they began dragging the police officer. So we get on scene and we're talking to a lady, and she says the people have been after me. They're chasing me. There they are, right there. They're watching me everywhere I go. They're going. Their picture's completely paranoid. Well, it turned out she was a schizophrenic on meth. So a lot of issues right there. But obvious mental status when she's saying that the government is chasing me and they're after me. Um, you got to look for those things. And obvious mental status changes your assessment because now you got to fix that. Patients who appear unusually anxious and those who appear pale and sweaty. Just different ways to look at a patient. You're going to see a lot of different things from pale and sweaty, unusually anxious, mental status, all those things work toward together to find a problem. Um, Identify patients who may be critical, obvious trauma to the head, chest, abdomen, pelvis. When you start doing your primary assessment, you're going to see either a head wound, or you're going to see JVD, which is a jugular vein distension, or you might find um, sensitivity in the abdomen, a ablotion, different kinds of things, or pelvis might be fragile to the touch, and that's going to change. So as you do your head to assessment, when you find a damaging area, you stop for a minute, try to intervene with that situation, then continue your assessment. Specific positions and indicate stress. Tripod position. There's a picture of it in your book of a girl in a tripoding position, which you'll find with a lot of respiratory distress and leading to failure. Obviously, when they're in that mode, your assessment stops and you get that person on oxygen to help relieve that problem. Um, the Levine sign, chest pain or discomfort. Um, Patient's description of why the EMS was called. Again, why were we called here today? Maybe specific, abdominal pain, maybe vague, not feeling good. That happens. There's actually people, I'm just not feeling good for 2 days, and you have no idea why they don't feel good. They don't have any idea, but they don't. Then others are like, well, I've been throwing up for 3 days, and I can't. I'm just dehydrated, but I keep throwing up. You know, Interventions. So forming an impression of the patient is look, patient's age, sex, and position. Um, Listen, moaning, snoring, gurgling, respirations. Um, you know, Look at those things. Smell, hazardous fumes, urine, feces, vomitus, or decay. All those chief complaints. AVPU is a acronym that we use. So alert, verbal, painful, unresponsive. This will be on the test and this will be on your registry. This is a form of an assessment. Now, when you're past your registry and all that, AVPU is not as important, but it is very important for the test purposes. So, alert, document orientation to person, place, and time. AAO times 4, Glasgow of 14 or 15. Um, Alertness, verbal response. Maybe they're unconscious, but you're like, hey, Bob, and they open their eyes towards you. That's a form of orientation. And or, hey, Bob, what's going on? Hey, nothing, man. I just don't feel good. You know, Gauge that issue of or how their orientation is. Painful response. They're unconscious. Hey, Bob, what's going on? They don't respond. And then you cause some form of pain. A lot of times, when I see someone unconscious and they're not responding to me, I'll rub their sternum rub, and I'll say, "Hey, Brad, wake up a little bit. What's going on?" And maybe they move, their eyes open, and now they talk to you, or maybe they just groan. All that's got to be documented in your assessment. Unresponsive, they don't respond to anything. No pain, no verbal, nothing. Um, so AVPU, alert, verbal, painful, unresponsive. So it just stands for how they respond to you and their alertness. Um, Order of primary assessment will vary depending on patient's condition of airway, breathing, circulation. So, hey, Bob, no response. All that changes. Identify and correct life threats and gather information that will help you later in your assessment. So remember what you've done. So the next assessment you can trend. So I usually do about 3 assessments per call. Doesn't matter. I don't care how serious the call is or how unserious the call is. I do, and it's 3 different times of assessment just to keep my practice going. But at the same time, I want to follow a trend. So if someone that I meet is responding to verbal stimuli in the AVPU, for example, but then en route, about halfway, I check again, they're not responding at all, that's a trend of a downward spiral. Or if I gave, they weren't responding well, I gave them some glucose because their blood sugar was low, and then my next time I checked their primary assessment, they're responding to verbal, and instead of painful, that's a trend in the upward direction. So you want to watch those things so you know and get for your further assessment how things are rolling. Look for signs of life, including movement. Scan the chest for breathing. If no signs of such breathing or only gasping breathing are found, check the pulse. Because a lot of time that gasping could be their final breaths. Airway. If patient is alert and talking clearly or crying loudly, then the airway is open. We've already covered that. If the airway is not open or is endangered, take measures to open it. So head tilt, chin lift, jaw thrust, sweep, anything in there out, and put an adjunct in. Breathing. Situation is calling for breathing assistance if the patient is in respiratory arrest with a pulse. So they're struggling to breathe, but they're still got a pulse. Well, now the breathing is your primary motive. So not alert with inadequate breathing. So they're not responding and they're inadequate breathing. You got to take interventions with that. You begin to work with that situation. Has some level of alertness with inadequate breathing and has adequate breathing but signs suggesting respiratory distress or hypoxia. So, there's different gauges with the breathing. So you walk in, you want to find out, okay, well, they're struggling to breathe, they're in a tripod position, but they have a pulse. So my first thing is I'm going to intervene with that. Non-rebreather mask, get them going on oxygen, or they're not alert. So if they're inadequate breathing and they're not alert, but have a pulse, my assessment's the same and my response is the same. We got to get them breathing, but it may be different than a non-rebreather. You'll know in that situation whether they need a BVM mask or whether they need something more severe like a BVM. Anyway, or they have adequate breathing, but signs suggesting respiratory distress or hypoxia. So their breathing's okay, but they're still going hypoxic. So what's going on there, and how can we help? Assessing skin, good circulation. I've said that repeatedly in this section. Warm, pink, dry skin. Skin pink, warm, and dry. Shock, pale, clammy, cool and moist in the skin. I've had some heart attack victims that were in shock. They're pale, clammy, and sweaty. Clammy and so, or the patient's doing okay and they're pink, warm, and dry. So pink, warm, and dry means that they're perfusing. So everything that we talked about in chapter 9 and 10, all that ventilation, that means that the chest is rising and their lungs are filling their chest cavity. It's filling up with air and the alveoli is dropping off gas, or they're able to drop off gas and pick up good O2 and to the hemoglobin and take it to the cells, so they're perfusing. That skin is pink, warm, and dry. Pale, clam, cool, and moist is a situation where there is some form of shock, an internal bleed, so they're not perfusing, an outward bleed, they're not perfusing. All that will take our priority. 3 results of assessing pulse within normal limits: unusually slow, unusually fast. They're tachycardic or they're not, or they're bradycardic, or they're normal. So that's the 3 options you have. And each of those options will tell you during your assessment possible situations and life threats. If they're tachycardic, are they trying to compensate for something? Are they not perfusing? Is there shock? Is there, so you got to look at all the situations of normal limits, slow, fast. Check for a control of severe bleeding. Check for and control of severe bleeding. I remember going on a call, lady hit her head, and it was right at the arterial bridge above the temple, and she was just pouring out blood, couldn't get it under control. 3 bath towels were used before I got there. We got on scene and, was able to control the bleed by tamponade, shutting down that artery. So when you do that, it controls the bleed. Her skin was pink, warm, and dry, but by the time we got to the hospital, it was cool and clammy. So she was lost enough blood that her body was starting to go into a form of shock. But my assessment with her is I walked in, hey lady, how you doing? She gave me her name. She said she's doing okay. Her airway was open. Got that. Her skin was pink, warm, and dry, but she was gushing out blood. So my assessment went that far. My partner got on the monitor, got some blood pressure, got some vitals, but I went after the control of bleed. That's how fast that assessment went, because that took my priority. So determine priorities, fits what I just said. Treat any life-threatening ABC problem as soon as it's discovered. Boom, I went after that bleeding. To stabilize a patient needs to have vital signs that are in normal range or just slightly abnormal. So when you do your assessment, you find abnormalities and you stop and you take care of that life threat, if there is one, before you can move on. Control it, get that vitals in normal range, and then continue on with your assessment. A threat to the airway, breathing, or circulation, either actual or imminent, rules out stable. So any threat to the airway, breathing, or circulation, boom, the patient is unstable, get it taken care of. You got to determine those priorities. If no pulse, CPR is required. Determine priority. when you're going through your assessment, there are many times when it is not crystal clear what a patient's problem is. So there will be many possible diagnoses, some more serious than others. A patient's priority can change. So as you're going through your assessment, boom, oh my gosh, we got this situation going on. You go further on, oh my gosh, this is worse. So their priorities can change. Or when you fix one life threat, now you got another one. So it's not a perfect science with an EMS world, but when you start your assessment and you stop at life threats, ABCs, fix the life threatening issue, move on with your assessment. And again, it'll change from ABC to CAB. It determines on the patient. I hope this makes sense. There's a lot to this chapter, and I know you're going to read it, so that will help your situation completely. You know, if you look at your book, there's all kinds of pictures. Suction if necessary, develop a general impression, obtain it. So I want you to go to look at page 294 when you're with me right now, while we're talking, and talk about priorities. So one, the first picture shows you develop a general impression, obtain any complaints. Boom, as you walk in the room, you open the airway. Suction if necessary. Insert an oral, nasal. So you basically now you want to place an airway in that person so you can breathe for them. Evaluate breathing or rate of depth. Then you go on to apply positive pressure. So the BVM mask, breathing for the patient. Provide oxygen base to the patient. Identify and controlling life-threatening bleeding. So notice how the air was put first. Okay, so in the assessment, this was the most crucial. We got the airway placed and managed. Now we're going to go on to any life-threatening bleeding. Because if the patient's not going to breathe, the bleeding is not going to matter. So fix the breathing, then go on for the bleeding. Evaluate circulation and the pulse to make sure you're doing an okay job getting them turned around. Evaluate circulation, check skin color. So now that you got the airway breathing and you got the blood under control, now you want to check the perfusion. And then make a status transport priority decision, load and go or stay. And then request ALS or other assistance as necessary. So you look at that assessment, they walked in, they made a chief complaint, or found a chief complaint, got that airway open, suctioned the airway so it stayed open, put an oral and nasal airway in, and then started evaluate the breadth of depths, and then added a BVM to the picture to get that positive airway pressure. And then after they were under control with the breathing, they went to the next step, which was to control the bleeding. And then when you got that bleeding controlled, you can see the tourniquet on there and the sponge. Now they're checking the pulse, they're checking his circulation because now the patient's breathing and bleeding under control. I want to know that he's perfusing. And now that he's perfusing, let's make a decision. Do we got to take this guy now or not? And to get LS on the move. So that is basically, in a nutshell, how you would do an assessment. And it'll change from time to time because not every time is going to be a breathing problem. You know, some are going to be easy. I stubbed my toe, and that really does happen. So it will change. So there are many times when it is not a crystal clear. Boom. So patient's priority will change. Initiate priority transport if life-threatening problems cannot be controlled or threatens to reoccur. So initiate priority transport. You got to figure out, okay, man, we got to get this person on the road. We don't want to stay and play if it's going to cause the patient danger, but we also don't want to load and go if it's going to cause patient danger. So it's a very methodical process to do an assessment and decide what the best situation would be. Continue assessment and care en route. Like I said, we'll do 3 assessments. Today we had a call with an epileptic, got 3 assessments. One at the scene, made a load and go or made a decision on transport, got the person transporting, did another assessment in the ambulance still on scene, and then en route to the hospital did another one. Because you want to follow the trends. So think about it. Why must you continually reevaluate the primary assessment? Because you want to see trends. You want to make sure that the problem that you fixed is still fixed, and then you also want to find out make sure there's no other threats that you missed. And that may not be that accurate. That's just my opinion on that. Make sure to read the chapter. I have not read the whole chapter, but go through and make sure that's what they're looking for. How might normal findings in a primary assessment differ for a child compared with an adult? That's a great, great question, guys. Children, like I've said, can crash hard and quick. Their airway's smaller, all that kind of stuff. So there's a pediatric note in your chapter in 301, and I would like you to read it and answer that question for us, because it is a big thing. But a child is a little bit different than an adult. You do the same assessments, but when you find a threat in the ABCs or CAB, it can be more severe than what you might find in an adult. Um, but basically, kids are smaller adults. But children in a mental status, for example, though, children 1 to 5, that's for adults, but infants to 1 year, if not alert, shout as a verbal stimulus, flick feet as a painful stimulus, crying would be infants' expected response. So there's a different ways of doing your assessment. As for children, but see the airway management chapter on how to do a infant to 1 year old. Um, but it all changes, and there's a great graph on page 303 on mental status for adults, children, and infants. Read that as well. It's a great example. So, anyway, chapter review. I breezed through that pretty quick and hopefully not too fast, but read your book. The primary assessment is a systemic approach to quickly finding and treating immediate threats to life. So basically, head to toe, bam, AVPU, get their alertness, ABC, CAB. Basically, a primary assessment is simply walk in the room, finding the chief complaint, starting your assessment, and stopping and taking care of life threats. Um, Fix that life threat, and then move on with your assessment. The general impression, although subjective, can provide extremely useful information regarding the urgency of a patient's condition. And that's absolutely true. It can provide extremely useful information regarding the urgency. And you should have that urgency picked out within 60 seconds of being on scene um, of what needs to happen. The determination of mental status follows the AVPU approach, alert, verbal, painful, unresponsive. Um, where does they fall into the AVPU category? Evaluating airway, breathing, and circulation quickly but thoroughly will reveal immediate threats to life that must be treated before further assessment. And that's absolutely the way to go. Your approach to a patient will vary depending on how he presents. The American Heart Association recommends a CAB approach for patients who appear lifeless and apparently are not breathing or have only agonal respirations. This begins with a pulse check and a chest compression if there is no pulse. Start to CAB, and that obviously that changes your assessment. If your patient shows signs of life, moving, moaning, talking, and is breathing, you will take a traditional ABC approach: airway, breathing, circulation. How are they doing? Remember that the ABC is a guide to interventions that may be taken. You will choose your interventions based on the patient's immediate needs. They may be done in any order that fits the patient's needs, and that is important to understand. Every patient is different, every call is different. This is a formula to follow, but it can't be the law because ABCs is not always the way to go. Um, the patient's priority describes how urgent the patient needs to be transported. It isn't how to conduct the rest of your assessment. So again, the patient's priority describes how urgent the patient needs to be transported. It isn't how to conduct the rest of your assessment. So basically, if you're going through a head-to-toe assessment, your primary assessment's being done, you find horrible life threats, but absolutely out of your scope, and you're like, man, we gotta get this patient moving right now. You get them in the ambulance, however, from a scoop to the vacuum mattress to the stair chair. You get them into the ambulance and you're transporting, but as you're transporting, you change your assessment to fit, intervene with that life threat, but keep assessing the patient. Um, Determine if a patient is responsive or unresponsive, whether the patient is an adult, child, or infant. You don't know that right away. Rapidly identify the need for immediate airway intervention. So if you're doing your assessment and they're not breathing, or they're, but you also see they need assistance, so you got to bam, okay, we got to get an intervention going on here with the airway. Their pulse ox is dropped and they're not getting good ventilation. Determine if the patient's condition is stable enough to allow further assessment and treatment at the scene. Again, you don't want to stay and play if it's too dangerous for the patient. So as you're assessing, you got to determine, okay, we got time. I interview with the life threat. Okay, they're not, oh man, they're not breathing real good. They're shallow. Let's get them on a non-rebreather and see how that does, and then continue your assessment. Or is the patient's condition so bad you have to give them the hospital because they might have to intubate and do ALS interventions? You have to make that call. Now, for me, if someone's tripoding and their pulse ox is low and they're ash color and they just they don't feel good, I'm going to put on a breather on and continue with my assessment unless they're in respiratory distress or failure. I don't want to stay in play if it's going to cause them danger, but I don't want to move them if I feel like there's something critical going on too. So you don't want to miss something, but you don't want to stay in play and cause danger. So determine if the patient's condition is stable enough to allow further assessment and treatment at the scene, or do you need to do that en route? What factors will you take into account in forming a general impression of a patient? What factors will you take? Bleeding, just look at the book and kind of answer these questions for yourselves. How should you assess a patient's mental status with regard to the AVPU? Levels of responsiveness. Um, how should you assess airway, breathing, and circulation during the primary assessment? And what is meant by the term priority decision? So these questions we will cover in class, even though we're covering this chapter right now, we will have to revisit this because I want to make sure you get it and pass. A middle-aged man, you can read that on your own. And if you are alone, what factors do you consider in deciding what to do first? Why? So if you're alone, what are the factors you consider? Mine, if I was by myself, was first off, what other resources do I need to get here right now? You don't want to be on a call by yourself. You don't want to be taking care of somebody yourself. So get help moving. But anyway, that's a quick chapter there. But I know you guys have listened to a lot of me today, and I've taught a lot today. Been a busy day. So hopefully, guys, next chapter 13 is on vital signs and monitoring, getting some more hands-on stuff. But please give me feedback, guys. I want you to text me and let me know that you've watched these chapters today so I can record you in the attendance log for Memorial Hospital. But I also want to know if these are working. I don't want to work this hard, work hard at something that you guys aren't interested in. So if these don't help and only classroom helps, let me know. To me, I thought it might be easier for you guys to have some class time, but also have some time where you can stay home and listen to the PowerPoint and do hands-on in class. So we'll work it out. But please give me feedback. I want to do a good job teaching you guys so you'll pass and be great EMTs I know you can be. So call me with any questions. Even though I'm out of town, please call me if you need something. Text me. I'm still working. I'm just out of town. So appreciate it, guys, and take it easy, and we'll talk to you soon. Wednesday, don't forget, 6 o'clock, CPR first aid. I would like you all to be there. Even though if you've had first aid, sit through it and get refreshed and help out the students that haven't had it. And then also, Eric is going to help us some labs from these chapters that we talked about today. So talk to you soon. Bye.